Okay, good evening, everyone. Welcome to our Firefly webinar special. Tonight I'm in the west coast of Ireland in County Leitrim, and I'm connecting with my colleague and great friend and wonderful mentor, Chris MacLean, who's based just on the suburbs of Vancouver. We've got a 45-minute sort of in-depth presentation tonight for you, and I think you're going to find this really interesting. We will provide you with a PDF copy of the presentation, which we can email to all of the attendees. If you've got any questions, if you can direct them to the questions and answer button, which might be at the top of your screen or the bottom. And then at the very end of the presentation, we can get Chris to answer those questions. So let me tell you a little bit about Chris. What's interesting about Chris is that his story or his journey has taken him from a very sort of clinical, practical perspective on custom-made foot orthoses and their use in clinical practice. And he's journeyed into the realm of science and got his PhD, and then eventually became the lead scientist in one of the world's probably leading biomechanics and gait labs in Fortius in Vancouver. He's also been very active in the North American podiatric model in terms of prescription foot orthoses laboratory meetings. And indeed, that's when I first met Chris around about 18 years ago now, Chris. So the first one I went to was in Montreal. Not sure if you were at that one, but then from there I traveled to Paris Orthotics, where I met you there. So Chris has been a great friend and has shared lots of expertise with myself and with the Firefly team, and that's something that we try to bring to Ireland and to the UK podiatric profession. So Chris, I think really just if you go ahead and get into your presentation, and I hope everybody enjoys it, and we'll ask some questions at the end.
All right, that sounds fantastic. Thank you very much, Martin. Thank you. So good evening, everyone, and thank you, Martin, and to you and your whole team for inviting me this evening. It's 12 noon here in Vancouver, but as you know, I'm on the west coast of Canada and about 8-hour difference. So it's great to be here this evening, and thank you for taking the time to share a bit of information. And I look forward to the questions at the end. And so I'll tell you a little bit about this presentation. I first gave it about 2 years ago, and really the purpose was to share with people information around the influence that the foot has on lower extremity dynamics, but also what occurs from the hip. And in our community, we were seeing a movement away from people taking the time and care to thoroughly assess foot and ankle biomechanics, and they almost switched to focusing on the core and hips, which are absolutely important, but without looking at both ends of the spectrum, you're missing out. So the purpose behind this really was to help different professions, and there are different disciplines that have different points of view, to understand sort of the holistic approach. So I'm going to spend the next 45 minutes or so just providing you with a little bit of history, and this should be fun. It's just really, I want to share with you how we really started looking at footwear. And a lot of the work that was done focused primarily on running injuries, and that started really in the mid to late 1970s. So I'm gonna talk about the pronation years. It sounds a little bit like a Monty Python movie, but the pronation years, and some of the key papers and work that were done during late 70s into the 80s and through the 90s, and then this almost pendulum switch to a focus on the hip that occurred around 2000, and pretty much everybody on here is likely a podiatrist or a foot care specialist, but the physiotherapy community in particular switched to sort of this view of the hip down, a proximal to distal sort of model. And so I'll share the hip years with you. And then I want to kind of dive back into this and look at sort of the two different perspectives and where we are today. And really, we're looking at a very complex system. It's not as easy as the foot influences everything up from the ground, and it's certainly not as easy as the hip is the only driver of motion from proximal to distal. So trying to simplify this is difficult. I'm going to finish up and just share with you how I've explained this to athletes, to patients and clients over the last 7 or 8 years in terms of the kinetic sandwich. And I'll talk a little bit about the movement of the center of mass and how our lower limb is really sandwiched between that center of mass and the surface, the ground. And then I'll finish up just reviewing a little bit about what we've learned about custom foot orthotic therapy and where I think we need to go as we move forward. So as we start this, I'm going to talk about the first era, part 1, the pronation years. And this sounds a little bit like the meaning of life. Monty Python, who I'm sure you're familiar with, and certainly for some of us, it has been the meaning of life, trying to understand these different aspects. Now, back in the late 70s, there was a running boom through the 70s, and in the late 70s, really some of the first research that was done looking at epidemiology of running injuries, also the influence of footwear. A lot of it originated in the late 70s at the University of Oregon. And you'll see here up in the top right-hand corner, we have a picture of Belushi, and he was in a movie called Animal House at about that time. The late 70s, and Animal House was filmed at the University of Oregon. My mentor, Joseph Hamill, was a student of Barry Bates, who you'll see listed here. Barry Bates was a biomechanist who started to look at footwear and running shoe design right through the mid to late 70s. And so the interesting story is Joe Hamill was in the cafeteria when the infamous food fight scene was shot for Animal House when he was a doctoral student. So that's the connection between myself and that work that was done at the University of Oregon. There were 2 key papers that are often cited that came out at that time. And one was by Stanley James and Osternig and Barry Bates. This paper cited more than most, looking at running injury epidemiology. And we were trying to understand the patterns of injuries that are typically suffered by the distance runner. But very soon afterwards, the same group, and this one was led by Barry Bates, started to look at footwear, and particularly custom foot orthotic intervention in runners. And so this really kicked things off, and many studies have come since. But it was where we really started to look at foot orthotics as an effective means of certainly treating running injuries, but also perhaps in preventing. And so in their cohort, they looked at about 180 distance runners. And of these runners, the clinical physicians who were part of the research group had defined about more than half of them as overpronators. This is still a term that's used freely. We don't really have that defined, but clinically, they felt that these people displayed overpronation or prolonged pronation. And of that group, about 83 individuals of their 180 received orthotic intervention. And they had a very positive response of about 78% in that these runners were able to return to their previous running program. So in Bates' work, one of the things that they looked at, and this is really the beginning of kinematic analyses for running and footwear interventions, they looked at the rear foot angle, and the rear foot angle, or the angle of the rear foot calcaneus relative to the leg and the frontal plane, was really one of the first variables used to try to understand the movement of the foot. Most of the motion that occurs in the frontal plane occurs at the subtalar joint, as you know. This is a very old graph, but Bates were really among the first to show the difference between a barefoot runner. So you can barely see it. I'm sorry for that, but there's increased eversion is positive in this case on the horizontal axis. And this dotted broken line, the peak is represented here by the arrow. That's a barefoot runner. These individuals measured barefoot. The dashed line is when they had their running shoes on. So there was a decrease in rear foot eversion angles with the shoe alone in the magnitude of 2 or 3 degrees. With the orthotic and shoe, there was a decrease further of eversion by about 5 to 6 degrees in the study. So this was really one of the first papers that showed this and showed a relationship or an association between what we know as foot pronation and running injuries. And the fact that so many responded positively really kicked off research on not only how foot orthoses work, but also on their clinical efficacy or the positive outcomes that they can lead to. So as we move into the 1980s, and actually a lot of work also occurred at University of British Columbia, where I did my master's work. And these two are highly cited papers on running injury epidemiology by Dr. Douglas Clement and Jack Taunton. These two were my mentors in the early 90s. But they started to look at injury patterns as well. And this is right around the time of Ferris Bueller. So now if we're moving ahead into the 80s, for those of you who were around, it was a great decade, and Martin can attest to that. And Clement and Taunton started to look at large cohorts of runners that presented with running injuries to understand where do people typically get hurt as distance runners. But they were also really the first to talk about coupling, or a breaking down of coordination that may be a cause for injury, and how that relates to excessive eversion or increased pronation. So they were really the first to put on the table that perhaps there's a coordination issue here. And the early sort of presentation of this idea was that as the foot hits the ground at initial contact, the foot in running will evert or pronate till about mid-stance, and then reverse and supinate or invert to toe off. And coupled with the eversion of the foot is an internal rotation of the leg or tibia and a flexion of the knee. And this is the key mechanism for your body to absorb forces as you're landing. But there is a key reversal that occurs at approximately mid-stance, where you have the supination or inversion of the foot coupled with external rotation of the leg and an extension of the knee. And this is really where Clement and colleagues first suggested that perhaps it's a decoupling, and they were looking primarily at Achilles injuries at the time, that leads to this, could be potentially a mechanism for injury. So here, and these are the original diagrams from 1984, they just showed a foot strike or initial contact, sort of the eversion of the foot, an internal rotation of the leg. We see here as you go to mid-stance, they propose that that likely reverses. And in a case where it may be deleterious, maybe it's that the foot is everting in a prolonged manner, so everting or pronating beyond mid-stance. The leg wants to go into internal rotation with that foot, but because knee extension has initiated, there's actually an external rotation moment occurring at the knee. So it's almost like a corkscrewing effect or a wringing out of the Achilles tendon that they were describing. But it was, I think, one of the first papers, among the first, to talk about coupling and coordination. And that's really what we're going to dive into in a few minutes as it relates to the influence of the foot, but also the influence of the hip. More recently, Tracy Dirks has shown this and many others, but this is probably a great way for you to understand this graphically, is the coupling that occurs from initial contact, which in these graphs on the left is 0%. You'll see percent stance on the horizontal axis. Toe off is 100%, and mid stance occurs at approximately 50% of that stance phase. And if you look, you have the knee in the sagittal plane, you have the tibia in the transverse plane, and you have the foot or calcaneus in the frontal plane. When there's foot contact, that knee flexes, the tibia internally rotates, which is positive here, and the foot everts, which is positive. And you'll see at about mid stance, those three rotations in a synchronous manner reverse to knee extension, external rotation of the leg, and inversion or supination of the foot. That's considered to be healthy state. And what many have looked at is the timing of these events, but also the variability, which we looked at in some of our research on foot orthoses. Here's an individual. If you're more of a visual person, we can break it down from an anterior view. This is actually a runner that I worked on a couple of years ago. If you look here in the bottom left-hand corner, you can see he was a mid-foot, forefoot striker, barefoot. The knee is in a flex position at landing. Flexion increases as they get to mid-stance, which if you like to use video, sagittal view, if you see the knees side by side, that's approximately mid-stance, the swing limb and the stance limb. And then after mid-stance, you see the extension of the knee to help with propulsion and then eventual toe off. The same time points, looking from an anterior view, you see that the leg is externally rotated. Typically, the foot is quite inverted. They come in to landing. There's an internal rotation of the leg and an eversion or pronation of the foot. At mid-stance, typically you're at your maximum internal rotation of your tibia and foot eversion. And then after mid-stance, these reverse: external rotation, supination, or inversion to toe off. Okay? So that's something I'm sure you've heard of before. So further to this, the real focus, and unfortunately the greatest interest group, tend to have focused on patellofemoral pain. And as we move into the 2000s, a lot of the emphasis was on ACL injuries. But in the running world, patellofemoral pain was the #1 occurring injury. That was determined by Bates and Stanley James that I mentioned before, and also Taunton Clement. So everybody was trying to figure out, why do we get all this patellofemoral pain? And so Dave Tiberio, who I got to know while I was at UMass, he for years was on faculty at the University of Connecticut. He sort of proposed an idea about why we get this patellofemoral pain and how it may be connected to foot pronation. And so he proposed sort of one of the first theoretical models of what the coupling looks like above the knee. I think Clement and Taunton touched on it a little bit in terms of tibia and foot, but what's happening with that femur? And so again, this group talked about at a mid-stance, we should have a reversal of those three segmental rotations. And the idea here is that if the foot continues to pronate or evert, so it's prolonged pronation, tibial external rotation won't occur as quickly as it should. So the tibia will follow the foot, and yet you've got this knee that wants to extend to get through mid-stance. And so what he proposed is that it's likely an internal rotation of the femur that occurs to compensate for this. And this is where people started to talk about increased Q angle, and fortunately that helps with knee extension, but it often throws off the patellofemoral mechanics, and so it's not very good for that joint, but it's good for the knee joint itself. So this is where the focus started to look more at the movement of the femur and how that could be influenced by what's occurring at the foot level. Shortly after, in the early 90s, my mentor, Joe Hamill, looked at footwear and how that might be contributing to a decoupling or a breakdown of these coordination patterns. And so Hamill and Barry Bates wrote this paper in '92 where they compared 3 different types of running shoes. So at the top here, we've got running rear foot eversion, now negative. And then you have knee flexion extension down below. And they looked at 3 different types of shoes. C1 was a hard midsole. C2 was a midsole of a durometer you would typically find in a running shoe. And then C3 was a very soft midsole. So this would be similar to what we did with orthotic therapy, looking at different durometers of midsole and how the shoe affects the dynamics of the foot. Well, if we jump down here, we'll see between those 3 conditions, there was very little effect that occurred at the knee and the sagittal plane. Those 3 shoe conditions didn't really affect knee flexion extension. But if you look at the rear foot angle, you'll notice that in the hard shoe, which is the bold line, and the thin solid line, which is the typical durometer of midsole, there was very little difference in the timing or the magnitude of rear foot eversion. But once we get into the soft shoe, you see that now the pronation or maximum eversion occurs much earlier in the stance phase and to a greater degree. And this was one of the papers that started a conversation about how important shoe stiffness and the composition of running shoes can influence this coupling or coordination. So as we got into the 90s, we had a pretty clear picture of how athletes get injured. And this focuses on running because this is the area where people have studied it the most. However, it's no different than other athletes in different sports. Orthotic therapy became a very common modality that was prescribed to help manage these injuries. And Janice Ng, who's here at UBC, she studied the efficacy of these devices, and it was really one of the first papers that showed that orthotic therapy can lead to a positive clinical outcome. I think Angela has her hand up. Angela, do you want to put something in the chat area or Q&A? Maybe it was a misfire. Anyhow, Janice Ng and Peranowski published one of the first papers showing the efficacy or the therapeutic outcome, positive outcome of orthotic therapy in individuals with patellofemoral pain. And there were a lot of studies that followed, and a lot of these studies had some challenges. And this is kind of why I got interested in this area from a PhD and graduate perspective. But there was a lot of variability in the orthotic studies, and I have a huge library of them, where the quality of research is a little bit questionable. Typically, the groups of researchers, it's a very small interest group. So if you look at other areas like osteoarthritis, diabetic foot, ACL injury prevention, it's a pretty small group of individuals that really have a keen interest in understanding orthotic therapy and footwear interventions. The other key thing, which we've talked about a great deal, is the variability of what is called an orthotic or an orthosis. And that has varied in the research world from EVA wedges to prefabs to custom devices. It hasn't been really well defined on what a custom foot orthosis is. And so there's a lot of variability in what the intervention has been that's been provided to subjects or participants in studies. And then the other area that is very difficult, and this, you know this in your clinical life, is that it's very difficult to treat or prevent any injury by only one means. And so it's usually the collective effect of exercise with orthotic therapy, with shoe prescription, and other modalities that leads to the positive outcome. So to just single out one intervention, is a difficult thing to try to achieve. Now, as we got through the 90s, the pronation years, we had a pretty clear idea on injury patterns in distance runners. And this is a slide that I put together a number of years ago that just kind of just exhibits injury patterns over the last 30 or 40 years. And you'll notice here, a lot of this work was done at UBC, University of British Columbia. Doug Clement, Taunton, I've spoken about already, and McIntyre was another sports medicine physician. But you'll notice that the top 6 injuries in distance runners, patellofemoral pain has always been number 1. Iliotibial band syndrome, which I want to talk about in just a moment, is another, number 2. This is similar in males and females. Females have a slightly higher frequency in these 2 particular injuries than males. Plantar fasciitis, which we're all familiar with, Achilles and patellar tendinopathy, and then tibial stress syndrome. So we've kind of known that these are the top 6 in males and females. And if you look over the decades, the 80s here in purple or indigo, the maroon is sort of the 1990s, and then into 2000s, we don't see a whole lot of change in the frequency of these particular injuries. And in fact, in some, iliotibial band syndrome is most discussed. We've actually seen an increase in the frequency of this particular injury. And in one of the papers by McIntyre in 91, he tried to describe what he proposed as perhaps leading to this increased occurrence of iliotibial band or lateral knee injuries in runners. And I'm just going to read this to you. As shoe technology has evolved, many shoes have attempted to provide rear foot stability and reduce pronation through the incorporation of a varus wedge and or a dual density midsole with a firmer medial post. These features may cause the runner to adopt a foot position with a relatively greater degree of supination during mid-stance, blocking pronation, okay? Thereby increasing tension on the iliotibial band. Additionally, it has been the author's experience that many patients with iliotibial band syndrome have presented with running shoes that have broken down on the lateral aspect with compression of the lower density foam. This hypothesis is supported by Secker et al., who noted that many of their patients with iliotibial band syndrome were wearing shoes with varus wedges, and that these patients had prompt relief of their problems when they switched to shoes without this feature. So what may have happened through the 90s is that perhaps the pendulum swung a little bit too far to the focus on anti-pronation orthotics and footwear. I remember people coming in with patellofemoral pain back in the 90s, and with orthotic therapy and a shoe prescription, they would resolve that particular injury, but they would come back with a new injury. And typically it was iliotibial band syndrome. So maybe we were overcorrecting individuals in their footwear. And I put the McIntyre quote in there because he was one of the first to sort of point that out, that there's a balance between supporting the foot and allowing it to pronate enough, and the importance of pronation, particularly in shock attenuation. So that's the pronation years. Now, if we move to the hip years, which occurred around 2000, we had an entire different switch. And a lot of this was driven from research on ACL prevention. So I'm going to go back to that slide because you're probably wondering about the hammer. So what I think happened in the 90s is, you're familiar with the saying, if all you have is a hammer, everything looks like a nail. I think that we perhaps overprescribed orthoses and maybe at times when it wasn't appropriate, and overcorrected these individuals. And as we get into the 2000s, I think the new hammer became hip exercises and focusing on proximal to distal. And I'll explain a little bit of this to you in part 2, the hip years. Right around 2000, this key paper came out, which I'm really surprised doesn't get referenced more. It's probably because it's so difficult to understand. But it was by Belchamber and Vandenbogert in the Journal of Clinical Biomechanics. And the title was Contributions of Proximal and Distal Moments to Axial Tibial Rotation During Walking and Running. Part of it was done at the University of Calgary, but these researchers asked a really interesting question. At the time, NIG had done a lot of footwear studies, and one of the observations is that not everybody responds positively to orthotic therapy or footwear interventions. And the question was, if tibial internal rotation is the key issue here, what is driving that rotation? Is it the foot, or is it coming from up top? Is it the femur and coming from the hip? And I'm not going to tell you what they found just yet, but this is a key paper and that really describes nicely the transfer of forces and energy coming down from above the knee that can influence the foot, but also the importance of what the foot does and how that can influence things up the chain. In other words, it's not one or the other, okay? And I'll share with you what they found in a few minutes. Chris Powers at USC was also very involved in looking at patellofemoral pain and also looking at ACL injuries, and started to look at the influence of the femur. So rather looking at the foot from the bottom up, looking at it from how does that pelvis and hip and ultimately the femur influence things distally. And they were quick to point out that here, if you look on the left, you sort of have a cartoon or a diagrammic of what typically happens in terms of Q angle. And the PT community has looked a lot at Q angle, which is really the position of the leg relative to the thigh and the frontal plane. And he was quick to point out that if you only increase tibial internal rotation, you actually decrease the Q angle, which is represented here. Sort of this bisection through the patella relative to the bisection through the femur. That if you internally rotate that tibia, you're actually decreasing the Q angle. So there must be something occurring with the femur. And like Tiberio talked about, increased internal rotation of the femur, that does in fact increase the Q angle and throw off the alignment of the patellofemoral joint. That's in the transverse plane. And if you couple that with an abduction or valgus of the knee, abduction of the leg relative to the thigh, that further increases that Q angle. So Powers was the first to sort of propose, was among the first to propose that perhaps it's coming from the center of mass or pelvis from proximal to distal that's influencing things down the chain. And so we're all familiar with contralateral pelvic drop, increased adduction and internal rotation of the hip that occurs. This occurs typically in mid-stance. And then the internal rotation of the leg, which we've talked about, and the pronation of the foot. But the genesis here, the focus now shifted to, okay, what's going on with that pelvis and hip? And is it driving things from proximal to distal? I mentioned that this has been looked at extensively in the ACL research. And just so you understand why the body moves in that way, it depends on the position of the knee joint relative to the ground reaction force vector. So in A here on the left, you'll see that typically in a healthy individual within normal limits in terms of dynamics or biomechanics, you'll typically see that force vector medial to the knee joint center. And so with most runners, they go into more adduction or varum, dynamic varum when they're running. Some individuals, you have an increased, increased moment arm because that vector is farther medial, excuse me, and that forces the knee into more dynamic varum. And they were really concerned in ACL with the presentation where that vector is lateral to the knee, and thus the knee goes into more valgum or abduction, so in toward the midline of the body. So the body moves depending on where the position of that vector is relative to the knee joint center. And a plethora of research came out through the early 2000s focusing on ACL mechanism originally, but then directly relating this to patellofemoral pain. And so a huge focus switched away, I think, in some disciplines, away from the role of the foot and the importance of the foot to entirely focus on the hip and strengthening the hip abductors and external rotators to try to stabilize the pelvis. And that Trendelenburg or increased contralateral pelvic drop that you see in some individuals when they're running. So there was this pendulum switch, and again, now we had a new hammer. The hammer being hip interventions for all the nails, for all the clinical presentations. And part of the reason and purpose that I put this together is that I had quite an experience the last 7 or 8 years working in a multidisciplinary facility where I was shocked, with the exception of the podiatrist on staff, how little people assessed at the foot and ankle anymore. They were going right to the hip, and the hip was attributable for all things that occurred below. And so I think that pendulum switched a little bit too far to the other side with a new hammer for all those nails. So what I want to show you now is that I don't believe that it's one or the other. And like many things that we talk about in podiatric biomechanics, for some reason, people want it to be all in the frontal plane or all in the sagittal plane. People rarely talk about the transverse, but that's reductionalism. That's trying to explain something that's really quite complex with one idea or one theory. And I think the same thing applies here. For those of you in the 90s who remember Seinfeld, they had the boxers or brief discussion. And most of us in our drawers probably have a combination of both. And so what I want to share with you now is that my feeling, my perspective is that it is a combination of the two. And the more we understand the influence of the foot and the influence of the hip, the better off we'll all be in treating athletes and our clients and patients. So the part 3 is this, what I've termed the kinetic sandwich. And I share this with you because this is how I explain it to athletes who are trying to understand what their body's doing and how to intervene, whether it's to prevent injury, improve performance, or to manage a current injury. So I often explain it as a sandwich, and hopefully this will be helpful for you as you speak to your patients and clients. So I'm going to go back now and I'm going to share with you about this Belchamber and Vandenbogert paper that came out in 2000. What was really interesting, and it was a very in-depth analysis that they did, and I've had to read it about 100 times to get clear, but at the end of the day, they were trying to answer this question about what's driving the tibial rotation that we believe is the source for a lot of these knee injuries, and potentially some below too at the foot and ankle. And what they found was really quite remarkable. They found that the driver of the tibia is quite different between running and walking and other tasks. So in running, the foot was the primary driver from distal to proximal. In walking, it was entirely different. The energy transfer, the power transfer, as they describe it, was more from the femur distally. And the key thing is, for those of us who manage and treat athletes and patients, is that it was different among different individuals. So it's not a clear one or the other. You know, it's not all about the hip, and I don't believe it's all about the foot either. And So now I'm going to try to explain that a little bit to you, because we tend to think about things in terms of the ground. Your foot hits the ground, and so it must be traveling up the chain. And I remember describing to people in the 90s, you know, if the foundation of your house is crooked, then everything on the second floor is going to be crooked. So we got to fix the foundation. And that's partly true, but it's a little bit more complex than that. So the kinetic sandwich idea, and this is just to share with patients because I think it's helpful for them to understand what's going on. So when we walk, run, we cut, or we jump, your lower limb is really sandwiched between the ground, which is obvious, but also the center of mass, which is right around the level of your belly button. It's the location around which all of your weight or your mass is centralized, and it moves. Okay, it moves up and down. And there's distal to proximal directed forces and energy that influence movement up the chain, which we've talked about, sort of that model from the 70s, 80s, and 90s. And there's also, at the same time, energy that's traveling down the chain. And that has a lot to do with the vertical displacement or the movement in a vertical direction of your center of mass. The vertical displacement of the center of mass, it clearly influences ground reaction forces, and it clearly influences how much force is insulted on your body when doing a number of different athletic tasks. And there's different ways that you can modify this. And we've learned this from gait retraining, which I'll speak about briefly. If you look across gait patterns, you'll see the difference between walking and running. So down below here, on the left-hand side, we have an individual who's walking at 1.8 meters per second. This is from somebody's paper. It's kind of goofy. I don't know how they filtered it, but usually what you'll see is a bimodal vertical ground reaction force, where there's a braking phase and a propulsive phase. And the magnitude of that force is typically around 1 to 1.2 body weights. And if you look at the center of mass, it displaces upward, comes downward as you accept weight, and then as you propulse forward, it goes up. So it oscillates up and down. And if you look at this, it's about 4-5 centimeters of displacement. When you go to running now, you have much greater displacement of the center of mass in a vertical direction. Here it's about 7 or 8 centimeters, and the forces go up to a much greater magnitude of 2 to 2.5 body weights typically. So if you think about that center of mass where all your weight is centralized, oscillating up and down with each stride, it's the downward where the forces go up. And that's something you can manage and intervene with, as well as what's occurring at the foot level. And so one of the things that we've seen in runners, which we can also apply to walkers, and I've used with particularly golf players with OA in the past, is you can focus on their step length. And if some of you have heard me talk about this before, but the frequency or your cadence is directly related to your step length. The greater the cadence, and we think the optimal cadence for most distance runners is probably around 180 steps per minute. If you increase your cadence, you naturally decrease your step length. And overstriding, or typically what's associated with decreased cadence, has been associated with a number of these injuries we've already spoken of. Patellofemoral pain, a lot of stress reactions and fractures that can occur in the tibia, rarely in the femur, sometimes in the foot. Certainly iliotibial band syndrome, labral tears in the hip, and plantar fasciitis. There's a stronger and stronger relationship being shown between these ground reaction forces and plantar fascial injuries. So overstriding can be an issue, and Brian Heiderscheit was one of the first to show what can happen in terms of step length if you increase cadence by 10% or decrease it by 10%. and typically the vertical displacement is reduced. So at a slow cadence, you've got the center of mass going like this, a lot of vertical displacement. And as you get into a faster cadence, shorter steps, it settles down. And so the forces of that lowering aspect are decreased. The foot typically comes back under the hip, which they've shown as well, and the angle of the foot when you land, it doesn't tend to be as dorsiflexed. Softening the landing is really the layman's terms that we focus on. So the cadence, stride frequency, and ultimately the step length are key. And this is an athlete actually that I saw a few years ago who we introduced an increase in cadence to try to settle down really chronic patellofemoral pain. And this is just the left and right side. The right's in red. And you look at the three conditions here. We had the individual run at a preferred cadence. So that's the cadence that they would select without us intervening. Their preferred cadence was 150 steps per minute. And that just means that in each minute, the left and right sides touch down 75 times. But you'll notice the solid line here, how greater the forces are, the vertical forces, when she was running at that 150 steps per minute. When we, with a metronome and a training program, introduced a 170 to 180, which is kind of what we think is optimal. We're not really sure why, but that seems to be what most coaches believe. You'll see how those forces were reduced. Here on the left, it's the dashed lines, about the same, about the same reduction, but overall the vertical force insulted on the body was reduced. And typically the loading rate, which is how aggressive the force is insulted on the body over time, that's also reduced as well. So as I mentioned, that's great for the runner, and it's tricky with walking, but if you can get your walkers to shorten their steps, that too tends to bring down that vertical displacement of the center of mass. So the other key thing that we've learned more recently is around, and this is a hip issue again, is around the width of your steps. So we see lots of athletes who come in with bilateral or unilateral crossover, which is the feet crossing over as they run. And that's ultimately increased hip adduction, or the adduction of the hip is the hip coming into the midline of the body in the frontal plane. And so I mention this because what you see with these athletes, because the hip is coming in toward the midline, now the foot typically is more inverted when it lands. And that foot will tend to pronate a greater degree and also much faster or at a greater velocity. And thus the pronation forces go up. So sometimes we've seen individuals that in the 90s we would have said were overpronators, but what we really needed to do was address what's going on at their hip to put their foot in a better position to land. And here's a couple of triathletes. This is a triathlete that I worked on a few years ago. She was, we had a nerdy way of doing this, but we measured the ankle center's trajectory when she was running and they crossed over. And so look how inverted that foot is at the point in time she's landing. And because of that, she had a lot of stress and strain in her tib posterior and a lot of medial tibial. So if you get the feet apart, increase the stride width, the foot then doesn't tend to be as inverted a touchdown. This one was another track middle distance runner from Idaho that we worked on. She was 22 degrees inverted when she touched down because her hips were in too much adduction. Typically what we'd like to see is about 8 to 10 degrees. So she was about 2 times the amount of degrees, but the result is that foot hits the ground, it cranks in, it pronates with greater forces, with greater velocity, and to a greater excursion. So think about that with your runners. If you can get their feet apart, it calms that down. So what have we learned about foot orthoses? And this is something that I want to circle back to the foot because I think we have focused a lot of energy on the hip, and we focused a lot of energy on the foot at a time that we didn't have as great a number of tools in the lab. Now with multi-segment foot models and with the accuracy of cameras, with instrumented treadmills, I think we need to build on our foot and ankle research. But what we have learned, and this will make some sense around some of these mechanisms I've discussed, is we're now seeing some fairly systematic results, meaning repeated across different researchers in a variety of papers. The decrease of pronation forces, or what we call ankle inversion moment, has been consistent over a number of papers, as well as the velocity of pronation. And in the early years, we focused a lot on 2D, so looking at sagittal frontal plane only, and looking only at rear foot angle. And my belief is the story really lies in forces, because forces cause injuries. There has been no study to look prospectively or retrospectively of the association between increased pronation forces and injury occurrence that I'm aware of. So I think we need to look at this, because at the rear foot angle, the changes are very small and highly variable. We've seen systematic results around aspects of vertical loading rate and also the impact peak magnitudes, and I'll show you those in just a moment. And these have been shown to prospectively now to be associated with injury and causative for injury, particularly with stress fractures and muscular strains. This is just an excerpt out of Irene Davis's fairly recent paper, where they prospectively looked at athletes who suffered injuries and found that they typically exhibited significantly greater loading rates. So here we've got the vertical ground reaction force for a rear foot striker. So typically with a rear foot striker, you see this little transient peak that occurs at about 15% of stance. The loading rate is really the rate of force development, or the slope of this line. And if that line's really aggressive, that's been associated with a number of different injuries. So they found in athletes prospectively that they exhibited increased loading rates and increased magnitudes for the impact peak. And some of the injuries that were most frequent were stress reactions, which it's been well established for about 20 years that tibial stress fractures, you typically see increased loading rates and vertical impact peaks. But muscle strains, in our practice at Fortius, I've looked at about 1,600 runners. The most frequent presentation are muscular strains. Then plantar fasciitis, Achilles tendinopathy, and then anterior compartment syndromes. So orthotics, we've shown, are effective at managing those key variables. And then this surprised me when I put this together, because there's been a lot of discussion around no evidence that orthotic therapy has any influence above the knee. And we certainly didn't find systematic responses at the knee, but papers are now starting to publish that hip adduction, that other key variable around these running injuries, has been reduced during walking and running. So these are some of the first papers that have shown evidence above the knee. So as we wrap up here, just in reflection, I think that whether you focus on the foot or whether you're in a different discipline and focus higher up the chain, it's important for us to look at this holistically. And I think we do need to return to and hopefully increase the interest group that focuses on the foot. I mentioned briefly, we now have tools and being able to look at the 3D kinetics, it's a whole other story. And thank you to Barry Bates and colleagues back in the 70s looking at the rear foot angle, but I also think we need to build on this. And there's lots of ways that we can do that. I think that for those of us that focus on the foot, understanding the role that the hip can play in putting that foot in a position that could get injured is really important. So some of these things, like increased stride frequency, increased stride width, they're free. and they're very effective. And your patients will love it if that's part of your recommendation to them as runners and even as walkers, which is not as clear, but it can be beneficial to them as well. I think we need to focus on the kinetic side of things, looking at the forces. And I'd love to see a study that looked at eversion forces and the occurrence of injury. Lots of great work being done with multi-segment foot models. The shoe has typically been a hindrance because you have to put markers directly on the foot, but we now, I think, can do work looking at barefoot running with a multi-segment foot model, but also with different sandals, and we're creative. Focus on transverse plane. Doug Ritchie and I, this is one of the things we've really been interested in with the Ritchie brace, is that one of the things that the brace does is reduce internal rotation of the tibia, we believe. And that too, from a proximal to distal perspective, may help to cut down on the amount of eversion of the foot. And then single subject designs. I think one of the things, unfortunately, that happens is it's difficult when you're a clinician reading studies, because you're often looking at group statistics. One group gets the orthosis, one group doesn't. And within that group, some people are going to respond positively, some are not. Some are going to have entirely different movement strategies in response to that orthotic. So understanding how different foot type presentations, different types of biomechanical patterns respond to orthotic therapy would be really helpful, I think, from a prescription or a clinical perspective. So I would suggest that we not throw the baby out with the bathwater. And this group tonight, I know, are primarily podiatrists and foot care specialists, but I do think some of the other disciplines need to understand the important role of the foot. And that has been lost a little bit, I'm afraid. And we need to think about orthotic therapy as a tool in our toolbox. I've often said that orthotics in Canada, at least, have been overprescribed, but they've also been underprescribed. There's a lot of people that never receive orthotic therapy that could truly benefit. And not to think of orthotic therapy or hip interventions as a hammer for all solutions. I tacked this slide on for your handout. If you're interested in looking at some of the more recent studies that have been done on clinical outcomes, I just put a summary there. Back when I was involved with PAFOLA, we were really reaching and searching for evidence around outcomes. And so this could be helpful for you in your practice. If you're having a conversation with a patient or athlete who says, well, I was told that this is all about my hip, why would I get foot orthotics? This can be helpful in educating your clientele. So I'd like to thank you guys tonight, and I'll take any questions if you want to put them in the Q&A session. I'll read each one out and then I'll try to answer it.
Oh, that's great, Chris. Thank you very much. Wonderful. I think one of the things that strikes me is that as podiatrists, many of us work in multidisciplinary clinics or work in communities where we have access to other professions. And, we do at times get into conflict in terms of, well, when do you prescribe a custom-made foot orthotic device or not? So at least having the sort of latest evidence there gives us some, gives us the ability to go and read those articles and, get up to date on what's important. So thanks for that. Let's see now. I see one question coming in there. Let's see, it's from Katrina MacLean. So the question is, great presentation, thanks. You were talking about changing the cadence with the metronome, which is great, and I've used this and it works well. But you also mentioned stride width and changing this. Do you have any tips on how to increase the stride width? How do you explain this to the patient?
Yeah, so thank you for asking that question, and I should add that in there. I do in other presentations. What we typically recommend is that the runner, and it's typically running where you see this. This isn't often an issue with walkers, but with running, we ask them to go out to the track. And I'm fortunate because I've worked with some really good running coaches that I've learned some of these techniques with. You ask them to go to the running track where they have lines that separate the lanes, and you ask them to, do a few laps in both directions, focusing on straddling the line. And what you'll find is that, and what we think is occurring, is that they're activating their hip abductors a little bit differently through swing phase when they do this. So it brings the feet apart. This often we think has more to do with activation of muscles rather than weakness or a strength issue. So we ask them to focus on straddling the line. And we always emphasize with runners to go in both directions, because asymmetries, we see them a lot in track athletes who always train in the same counterclockwise direction. So that's one way. The other way, if they don't have access to a track, is they can, if they have a treadmill, they can put a piece of tape down the middle of the belt, and they can focus on keeping their feet apart. And you may want to ask them to try keeping their feet as far apart as they can and running like that a little bit, and then bringing it in. But usually that works. And if they practice 3 times a week for 3 or 4 weeks, typically they'll adapt that movement pattern. You want me to read this, Martin?
Thank you. Yeah, you go ahead.
All right. So Ramsey, I've started using Podo Smart insoles for analysis. They have, I think, motion sensors and gyroscopes built in, and a multiprocessor. Can you measure impact forces when running along with?
He's essentially saying he can measure. It's probably not really a question, more of a statement and sharing some expertise there in terms of the Podo Smart insoles.
Some of these new in-shoe systems can, and also, I mean, I use Garmin a lot, can measure cadence or stride frequency, but stride width, some of the GPS systems may be able to do that, but I'm not quite sure. I'm not familiar with that particular insole. Plantiga is one that they're working on here in Vancouver. Yeah, there are some in-shoe devices, and that's what we're hoping, right? Because not everybody can go to a lab, and it's good to have tools to be able to measure in the field or when they're actually out doing their run.
Okay, there's just another little comment from Ramsey for the benefit of everyone, where he says there is a foot progression angle which it measures. So yeah, there's another tool, I don't know if people have come across it, that's very reasonably priced. It's called Run Scribe. So that's Run Scribe, and it's a little gadget that you attach to your running shoe. And it's, I think it's maybe $200, and the information you can get from that is quite exceptional.
Yeah, I think,
and I got that tip from Ian Griffiths.
Yeah, I think the question I'd ask if you're looking at the different systems is how they validated it. There's a lot of accelerometers available now too, which I think will be great if you're trying to soften the landing or the tibial acceleration, which typically leads to stress reactions in the tibia. So I'd ask the question of how have you validated this against the gold standard? Because some of them do extrapolate, and some of them have gotten in trouble for that. But if you're just looking for relative measures, so meaning if I change my style a little bit, what does this do to my stride frequency or my stride width? That's probably all that you need. The actual precise measurement's probably not as important, as long as you have a tool that's providing you with feedback on how you're progressing. There's a question.
There's
here
another
from Stephen.
Question there, Chris, which comes from Stephen Urry. Yeah.
No?
I'll read it out. Thank you, Chris, for a very clear presentation. Have you any thoughts regarding the relevance of accelerating the center of mass versus decelerating it?
Yeah, so that's a great question. And I've thought about it I've thought about it a lot. So I did a lot of work with Triathlon Canada, and I would often see runners that were running at 200 steps per minute. So the question here, I think, is, what's often we're dealing with people whose cadence is too slow. How do we get them to what we think is optimal or healthy? But what if they are well in excess of that 180? We haven't intervened with that, but I've often wondered about it and whether that's a healthy scenario. I'm not aware of any papers that have reported on if you want excessive cadence, because ultimately, and in the triathlete in particular, what they're trying to do is maximize their cadence and increase their step length, because that's what gets you going faster. So I'm not aware of that, but I've often thought about it and wondered.
There's another question that's just come in, Chris. This is from Sean Savage. How important is it to offer strengthening exercises for hip musculature when prescribing custom foot orthoses? Which exercises would you prescribe, and what are the major muscles you would work on?
Well, that's a great question. So absolutely, I think closed kinetic chain exercises of the hip abductors and external rotators. So more functional exercises than isolated hip abduction, hip external rotation. So doing things in weight bearing. To be honest with you, I have seen many people who, if you just looked at them running, if you looked at them in mid stance, you'd say, oh, there's all kinds of contralateral pelvic drop, excessive contralateral pelvic drop, increased hip adduction, but they're running at 150 steps per minute. And if you think about it, that compensation of that non-weight bearing side dropping in the frontal plane is because of increased forces. So I've seen that actually resolve and go away just by increasing stride frequency. If they're running at an optimal cadence and you feel that there is an asymmetry in strength or in motor control, then I would always recommend more functional type of exercises and weight bearing rather than in isolation. But I'm not the expert on that. I think certainly, your physiotherapist would be a good person to talk to, but I would look for closed kinetic chain where they're in weight bearing. I think that's where you'll get the best response.
Thank you, Chris. We have another question from Steph Owen. 180 steps per minute is mentioned a lot. Where has this come from? And how relevant is it to all athletes? Why not 185 or 170? Yeah. Why is 180 so important?
Steph, that's a great question. And you should be a scientist, because I think that's one of the questions that we don't know the answer to. In my experience, and that really came from the coaches that I worked with, and then eventually the papers that came out. We don't know why 180, and I can tell you that that's not optimal for some. For some people, 170 is better for them. And that example I showed you was that in terms of forces and decreasing forces, there was no difference really between 170 and 180. And the thing you have to remember too is that it's a balance between what's healthy for you orthopedically and running economy. So you burn more energy and it requires more energy to run at a higher cadence or a greater cadence. So you're trying to find that balance. And for some recreational athletes, they may be running at 155 or 160, and just getting them to 170 could be enough to mitigate the forces. But you have to train to do that because it does take more energy. And for them to finish the race or the run, you got to keep that in mind. And the other thing about cadence modification is you typically do it over 3 or 4 weeks, and you do it gradually. So you don't expect people to go out on the next run and go from 150 to 180. You have to work it up, and And I usually use metronomes that are available on iPhones to help people get the rhythm. And then there's one or two playlists on iTunes that you can download that runners have generously put together that are 100 to 180 beats per minute. So those are other resources that I'll often use once they get bored of the metronome sound, left, right, which happens pretty quickly.
Very good. Okay, that's fantastic. Chris, I think that's all the questions, or is there anything else coming in there? Oh, hang on, one more from Ramsey. Do you think it may be difficult for some athletes to increase their cadence because of their muscle fiber composition?
Ramsey, I haven't run into that. I think if you take that gradual approach to it, to allow for the running economy side and training side to catch up to that change in cadence, most people will come back and tell you, wow, I feel so much better because they've been pounding, so long on their runs. So I haven't had anything, and you wouldn't really know their composition. I guess you could make some assumptions around a sprinter versus a distance runner, but I haven't run into that.
Okay, that's great. We're kind of 9:10 in the evening here in the UK and Ireland, Chris. So I think maybe what we'll do is we'll wrap it up now. And a special thanks to all of the audience for turning up tonight, and a huge thanks to you, Chris, for sharing your expertise. And it's been really, really useful. If there's any other sort of questions that do come up after the event, perhaps people could email me directly, and then I can pass them on to Chris and we can get them answered.
Absolutely.
Well, there's just one little quick question. We may as well do this when we're here. Thank you, Chris. I love the hip-foot connection, and listening to you tonight has really shed a positive ray of light on my assessments. My patients really appreciate seeing a podiatrist assessing more than just the foot. So that's a statement, but that's kind of what we're all trying to do. So thanks for that, Martin. And lots of many thanks coming in on the chat. So, okay, folks, thank you very much. Have a great evening. And Chris, hope to talk to you again very soon. Take care, buddy.
I hope to come visit you soon.
Absolutely. That would be wonderful.
Okay, pal. Okay. Thanks very much.
Take care, man.
And thank you, everybody, for attending.